I have revised and edited this talk over and over again, simply to say to you how to build research infrastructure in 8 minutes. So instead of giving you a litany of things that you need to do, I finally changed it last night to say what I really, really want to say from the bottom of my heart and leave some of the logistical items out, because for that, we can always convene after this session. So let me start with some of my disclosures and straight take you to the first point I want to show you. And this is called the congruence model. If you go to any place where objectives and strategies are built, you'll see something like this. And the main emphasis of this model is that if doing research or building research infrastructure is about you and about me, it is not going to be successful. You have to put a bigger objective for the institution and their partners to become your partners. So you align your critical objectives with the objectives and capabilities of the people around you, and then with the institutional structure, and then build a culture of research. And I want to say something very profound here, which are not my own words. This is Michael Tushman from Harvard Business School, and he says, culture eats strategy for breakfast. That if you cannot align your institutional and healthcare objectives of your patients towards building a research infrastructure, it will seem like your own mission, and you will never be able to build partners around it. So, message one. Message two is that you should think about 4 different ways of building research infrastructure. Number one, scientific capability. You must start with identifying either within your institution or outside your institution source of knowledge and potential targets where you are going to apply that research for support of finances, colleagues, motivation, and most importantly, funding. What is it going to be directed to? Is it going to be industry-based exclusively, or is it going to apply to NIH or other agencies? So you should build scientific capability and an advisory board that will help you guide this. This advisory board doesn't have to be something fancy. It can be something very simple. It can be your colleague or colleagues down the floor on your hospital. Second is recruiting partners. That means people, medical students, your staff, your NPs, your PAs, your RNs. How do you mobilize someone to identify that patient in the ICU you want to recruit in your heart failure trial? Who is going to tell you? Are you going to be able to drop everything in the cath lab and go there? You need to find partners. Third is real-time research process control. I cannot emphasize more on this. Before you embark on research, make a simple Excel table that tells you what are you going to do and at what timeline, so people can hold you accountable for your words. And it also brings transparency. The fourth point is a flat organizational structure that is digitally integrated. You know, digital integration, people think of Google and something. It has to be a simple access database. But when I work with Josh Beckman and we work on a project and we put timelines around it, Josh Beckman can follow what I'm trying to do. He can see it real time. That brings transparency, and transparency builds credibility. Credibility builds your colleagues and brings them in force, and that is the most important infrastructure. So I want to say end-to-end integration and transparency is not just a buzzword. It actually is an important ingredient for research. Now, then comes the issues of logistics. Of course, your institution has to have a system to protect human subjects, certificates of confidentiality. Make sure when you accept data from people, they are reassured that it is not going to be found on my desk or in the cath lab table with some proprietary information. Be careful about it, and I think use those systems. If you set the culture that way, everybody else in your research team would align themselves to it. Now, clinical trials. Which clinical trials should you go for example? You know, I and Mana started in 2003 in Dallas, and we started with PAD and SVG and CTO. Why? If you pick up what we did was we went to all publications from the Veterans Health Administration, and we looked at the baseline characteristics of all of those publications. What was common was that PAD was 42%. A large number of proportion of patients disproportionately to Medicare population had ongoing bypass surgery, And a lot of them were left untreated because of difficult to treat lesion, because of interventional support, and that became our mantra, and that is what we projected. So if you cannot be experts of the trade, you will not be successful in building a clinical trial network that would support it. I could have never done PCSK9 research sitting at Dallas VA in the division of cardiology and in the cath lab. That would not be as wise. So you put all those things equal, and then is that complex human cartoon where all of this is gelling and merges together, and if you can't merge it together, you call Josh Beckman. Or I can give out his cell phone, or you call someone that you know who can help you put this all together and put this into a research consortium. The word consortium sounds big. Or what is a consortium? A consortium is a group of apparatus, capabilities, tools, and individuals. It can be 4 people and a toy, but it has to be something transparent, organized, where deliverables are defined and timelines are set. This is the structure of the XLPAD registry, and you can see how, and I'm not going to read out the names, how a vascular surgeon, an exercise physiologist, a health economist, a basic scientist, a clinical cardiologist all integrate and see that there is something for them. And if you look at XLPAD publications, we publish in all of these areas. We have outcomes of CLI, we have outcomes of endovascular, we have health economic outcomes, we have translational research, and we have put together, or tried to put together, all these partners under one umbrella. Second is that this registry engages 24 young faculty from 13 institutions, 5 women faculty, medical students 14, and 11 medical residents and 12 fellows who are first or second authors of most of these publications. Finally, I want to say the ultimate research infrastructure are the people around you. So build a shared vision, shared objectives, shared projects, shared processes so everybody can follow, and that will lead to shared glory. And for all the logistics, and I'll show you some slides about it in the last few minutes, my message to you is form partnerships and establish network. Message number 1 as an infrastructure. View this as human capital. Develop core capabilities around what you see and practice. Create objectives that are congruent with institutional and health improvement goals of your patients. Finally, digitally integrated. I emphasize, digitally integrated, could be an Excel file, high quality, transparent, credible research processes. That is how you will engage your partners. And for everything else, I refer you to 2 documents, or 3. AHRP document on organizational guide to building health services research. It is updated every 5 to 8 years. I read it diligently. I want to emphasize the Duke's National Cardiovascular Research Infrastructure. The website is there. And for everything that is remaining is the xlpd.org and my personal email I'll sell. And that would be a good resource to tell you what I have not told you today. Thank you very much, and thank you for supporting CVI. I hope it becomes part of your lives and ongoing professional careers. Thank you so much.
Thank you very much, Dr. Banerjee, for that inspiring talk. Make it sound so easy. Next, Dr. Beckman is going to tell us over the next 8 minutes how I follow up my patients post-revascularization.
Yeah, so much more of a mundane topic. Also, I'm not Superman. He was being very nice. I can't do everything he just said. All right, here are my conflicts that have nothing to do with this talk. Okay, here we go. All right, so I think the one thing I want to make clear up front is that we're going to be doing ever more amounts of lower extremity revascularization. Why? This paper just came out, or is about to come out, and it's going to show us that over time, patients who are revascularized with intermittent claudication a little, but more with critical limb ischemia, actually save their legs. This is a cohort of 104,000 patients in England, and just to make this clear, this is intermittent claudication, and these are different levels of critical limb ischemia, ranging from rest pain all the way to Rutherford 6. Okay? And what you can see is the sicker the patient, the more likely they are to get benefit, and that doesn't matter if it's endovascular or surgical. We're going to be doing lots of revascularization. I hate quoting a paper from someone who's on the stage, but I have a few slides now in a row from Phil's group because it just makes the point so nicely from VQI. If you take a look, this was 2,300 patients who underwent lower extremity bypass in between 2003 and 2011. And the first thing I want to show you is that over time, the number of procedures performed as secondary procedures increases. So it doesn't matter if you're starting with patients who have claudication in the light gray or critical limb ischemia in the dark gray. We are going to be doing ever more repeated procedures, and the earlier you pick up the need, the better things will be. Again, from the same paper, you can take a look here whether it's vascular intervention or bypass, whether it's claudication or it's critical limb ischemia. The first thing I want to say is that we used to think, or I think some of us still think, that you are way more likely to need a second procedure if you start off with an endovascular approach rather than a surgical approach. Now, accounting for the smarts of the physicians who made the decision as to which one to offer, you can see here that by 2011, the rates of requiring a secondary revascularization range from 22% to 19%. This is not a really big difference. This just suggests that both kinds of techniques really need to be followed up because they're going to require secondary interventions. And of course, we like to do everything perfect the first time, but people who need a secondary intervention, just as an aside, end up doing worse. This is their revascularization and amputation-free survival. And whether we're talking about, this is the first, people with the first revas and people with the second one, and the secondary ones always do worse, whether we look at RAO or male-free. All right. I think there's some good evidence, although this is one of several that I picked. This is one of the earlier ones, demonstrating that surveillance reduces the rate of total failure and adverse outcomes. And in the study of nearly 300 patients, what you can see here is that the patients who got, the greater the screening, the less likely they were to have amputation later on. Now, I think the real reason I was asked to give this talk can be seen from this slide. This is the best critical limb ischemia study, which obviously is what we all think of as the premier study in critical limb ischemia. And this is the schedule of measurements, when they're making measurements. And so just take a look at arterial duplex on the bottom, and you can make measurements at 1 month, 3 months, 6 months, 12 months, 18 months, 24 months, 36 months, and 48 months. And this is basically saying, do whatever you do at your own institution. This was not a mandate to do it at this time point. This was offering the ability to do it whenever people said they routinely get measurements. And so I actually don't think that there's any standard, or there wasn't any standard at the time that this was created. So I want to make one definition. What does screening mean? Screening can mean clinical examination. The foot may be a different color. The pulse may be worse than it was before. An ankle brachial index is a good way to do a screening as well. Has the ABI changed? And obviously, duplex ultrasound is something that would be at the highest level or order. So I am happy to say that a group of people got together, and Gene Zierler led this committee, and they created a nice guideline that came out of the Society for Vascular Surgery. And because I actually do this in this order already, I think they're geniuses. And this is what they recommend. So CE is clinical examination, ABI is obvious, and DUS is duplex ultrasound. And these are the recommendations from the Society of Vascular Surgery that came out this year. So everybody believes in an evaluation at baseline. You will notice that duplex ultrasound gets a plus minus in the vast majority of categories. Why? Because if the clinical examination is normal and the ankle brachial index is normal, or what it was the last time, you do not need to do another ultrasound. You will notice that infrainguinal vein grafts are the only ones that have a mandated measurement at 3 months because they are most likely, A, to have a problem, and B, to be fixable if you find the problem early. Everybody else and all the other measurements, and by the way, I want to make this clear, this is for open, 6 months, 12 months, and then annually. Okay, so again, the duplex ultrasound comes into play for most of them, aortobifemoral, iliofemoral, femfem, and axfem. If there's an ABI problem, infrainguinal vein grafts, they should get an ultrasound every time. For endovascular, for which there's a bit less evidence, so I think some of this is expert opinion, although I think it's quite reasonable. Again, you can see here that post-procedure at 1 month, everybody gets an exam, an ABI, and duplex ultrasound. At 3 months, when you're below the aortoiliac segments, you get the same kind of examination. For the aortoiliac segment at 6, 12, and annually, it's a duplex ultrasound only if the ABI is abnormal. And then what you can see here is that below that, it's duplex ultrasound at about the same rates as the open revascularization procedures. I think this slide and the one before it is the surveillance schedule that I would recommend, and I think is recommended now by a large stakeholder in the community. So in summary, the need for secondary interventions is high. About 1 in 5 revascularizations need a secondary procedure. Unfortunately, revascularization failure is associated with poor outcomes, so we'd like to avoid total failure of the revascularization. Current surveillance programs lack consistency across different programs in the United States, and I think standardization of screening should prevent the worst outcomes by preventing full revascularization failure. Thanks for your attention. I look forward to the question and answer period.
Thank you, Dr. Beckman. We're move on to Dr. Goodney from Dartmouth, who will be talking about disparities in CLI treatment. How can we change this?
All right, thank you very much, and thank you for the privilege of the invitation here. Disparities in CLI treatment. These are our disclosures, including a new project that I'll talk about later that's funded by the American Heart Association. I'm certainly excited about that work. I have 3 goals for the next 8 minutes, trying to try to make sure I stay on time, given that I'm moderating as well. Don't want to have to yell at myself. So we'll describe some recent trends in major amputation, describe the race and healthcare characteristics that are associated with higher rates of amputation, and lastly, introduce some work in progress, which we hope might elucidate more effective ways to limit amputation in the most challenging populations. So first, trends in amputations across the United States. We published this back a couple of years ago in 2014, and we're going to update it soon. We just got the new data back. But what it shows is essentially a good news story. On the x-axis is the year, and on the y-axis is the number of amputations per 1,000 Medicare beneficiaries. And as you can see, the line is going down. It's almost a 50% decline over a 4-year period in amputations for critical limb ischemia. And these are the important amputations, above knee and below knee amputations shown in these 2 lines here. 4-foot amputations have remained largely stagnant during this time period, but essentially it shows that overall we've done a lot of important work in the last 15 years in the treatment of patients with critical limb ischemia. We examine, though, some of the variation that remains for this disease process and work we performed as part of the Dartmouth Atlas of Healthcare. Shown here is a map where this shows any amputation occurring across the United States, and the lighter areas have rates of 1 to 2 amputations per 1,000 Medicare patients, while the darker areas are higher rates, 3 to 6 per 1,000. So 2 to 3-fold variation, and the darker areas show the problem spots across the United States. We looked at the variables to see what variables explain those residual trouble spots that still remain despite those declines. And it wasn't too hard to find differences. Each of these dots represents one of those hospital referral regions. There are 306 in total. And the y-axis here shows any amputation rate for Medicare patients with diabetes and peripheral arterial disease. You can see non-African American patients have roughly lower rates, 2 to 4 per 1,000, and not much variability across the country. But obviously over here, patients who are African American have much higher rates, up to 8 times higher, and there's much more variability. So race certainly is an important factor that we have to take on head on. We examined this slightly differently. We looked overall at amputation risk per 1,000 Medicare beneficiary per 10,000 Medicare bennies overall. And overall amputation rates are relatively low, 6 per 10,000. If you look in diabetic patients, somewhat higher, 1.6 per 1,000 or 6 per 10,000. 24 per 10,000 Medicare beneficiaries if you start looking at just diabetic patients with peripheral arterial disease. But if you look at diabetic patients who are African American, have peripheral arterial disease, have diabetes, and live in certain high-risk regions of the country, the rate is 6-fold higher, 36 per 10,000 Medicare beneficiaries. We then wanted to examine some of the factors about the treatments that these patients received and look to see if it was a function of time and lack of effect or new treatments. White patients with PAD and diabetes have seen a generous decline in low rates of amputation that started back in 2002. Black patients saw a greater decline, but of course their rates started much higher, so they still, despite the achievements that we've made, remain the highest risk population. And Hispanic patients are somewhere in the middle. We looked at the consistency of hemoglobin testing, hemoglobin A1C testing in these populations, and saw some small differences. We saw that inconsistent testing, basically not getting your A1C checked as you should, or low consistency testing was slightly higher in Black patients, and that was, as you can see, the black bars in this stacked bar figure. That translated, though, into important results. Those patients with low consistency testing, those who were not getting consistent A1C testing over time, had much higher rates of amputation. And that difference was much more important for those patients who are African American, as you can see here. So the highest amputation risks occurred in Black patients with inconsistent testing, and this showed a 5-fold difference, unfortunately, for that population. What about access to revascularization? It turned out that revascularization rates, and this is endovascular revascularization rates, were shown here. They're actually higher in Black patients. That's what you would expect. If this is a sicker population, they should probably be getting more invasive treatments. So it didn't seem like it was hard to get access to expensive things like endovascular revascularization or open revascularization, as shown here. But simple things like just getting your lipids checked along with your A1C, those rates were uniformly lower for African American patients. And again, for A1C rates, again, lower in African American patients. What about health policy? If you look at payment models in Texas for the care of patients with CLI, safety net hospitals who disproportionately care for African American patients were paid $600,000 in Texas for the care of patients undergoing amputation. Revisions with bundled payments would actually take all those payments away from safety net hospitals, turning the $600,000 of remuneration that those hospitals received into a $200,000 loss. So even health policy is going to disadvantage these populations. So overall, it's a challenging problem. Black patients receive poor, less consistent, simple, and inexpensive medical care. They have universally higher risks of amputation despite access to expensive revascularization, and they're cared for by financially threatened healthcare systems. What are we going to do about this? That's obviously a pretty big row to hoe, as we say. We're going to start at the beginning, though, and this is how we're going to, we hope we'll make at least a dent in this trouble. This is a proposal that was recently funded by the American Heart Association between our institution and Brigham and Women's, entitled Understanding the Pathobiology and Predictors of Limb Ischemia to Improve Outcomes in Peripheral Arterial Disease and Diabetes. And Mark Banaka is leading this effort. This project has 3 parts. First, we know that the complex pathobiology in CLI is poorly understood, so Mark Feinberg is going to lead a basic science project looking at wound healing and microRNAs. We also know that it's difficult to identify how individual patients are going to respond to the different therapies that we have to offer. So Mark Banaka is going to lead a risk prediction and personalizing therapy project in the TIMI study group. And finally, my job, as when you've heard about some of the work here already, is to identify those populations that are going to be most challenging and the systems of care that need the most attention, and try to figure out how we can better deliver simple and inexpensive therapies in those populations. An important aspect of this project is it's not isolated to just academic institutions. We have community outreach planned in several ways, social media highways. Community outreach efforts are planned as well. Community education efforts are going to be part of the project at each of our institutions. And lastly, we're going to make sure that we continue fundraising efforts to continue this work. We hope that these synergies will help to begin to better understand the pathobiology, the predictors, the treatments, and the systems of care that are necessary to prevent CLI in these high-risk groups. So in summary, it's been a pleasure here today to share some of the challenges and where I think the amputations that we really need to deal with remain. I think the low-hanging fruit has been dealt with, and our iterative progress really needs to be in these highest-risk populations, and I look forward to the work ahead. Thanks very much.
Okay, thank you, Dr. Goodney. We'll move on to Dr. Das, who will be giving us master's advice, how to overcome challenges in practice.
Again, I provide the entertainment during these meetings. So my job over the next few minutes is to talk to the fellows and the folks that have been in practice the shortest and give them some advice about things that they are going to face and potentially face at places even after they've been in practice for a while. How to overcome challenges in practice. These are my disclosures, not germane to this. So I'm just going to touch on 4 common challenges in practice, especially early on, is developing case volume, introducing new technology into a center where you don't have a reputation yet, dealing with specialty competition, and local politics, which is what all politics are. Before you start, I think you should understand a few things. Maybe they're uncomfortable truths, One, you were not brought into this practice because your group was just too busy. You would probably not be doing all the complex cases despite the fact that's what you thought. Your experience in fellowship will be minimized very quickly by those who have been around there longer than you, and the competition will probably magnify the mistakes in judgment that you make, especially when you have bad outcomes. So the idea is to collaborate. And the cath lab staff and the vascular staff will not be open to your new ideas because they've never seen some of the stuff that you're going to bring to them, and they may never get that way. So early practice do's and don'ts. Don't overwhelm people with your newfound skills. Be discovered for the kind of work that you can do and develop a local reputation of early adoption. And that's probably the best advice I can give you. So what's challenge one? Developing your case volume. So one, be professionally honest. Don't do cases you're not comfortable with. Be very clear about your upfront experience and just collaborate with people, because when you learn something, you can see one, do one, then teach one, you'll get plenty of cases over time. How do you find the patients? Well, people say, I don't have any vascular patients in my practice. Well, if you're a cardiologist, you're wrong, because your coronary disease population is full of them. Many of them are symptomatic and they've just never been asked. And many of these patients have lifestyle limiting problems, which are the only ones you should be treating. Screening for things like carotid and AAA are important parts of vascular practices, and venous disease is absolutely part of your evaluation. And then developing outreach clinics. So building the referral base to increase your volume is from within your practice. How do you do it? Teach your non-invasive testing to your partners. They may not even know how to do appropriate ABIs or some of the things like Josh had just shown us, how patients should be followed after they have surgical procedures. Teaching angiography, I taught pretty much everyone around us how to do good peripheral evaluations and make sure people are clear on what the indications are. We have screening programs in our practices, and I think that those are things that are easy to incorporate. Duplex, segmentals, and also patients that have symptoms could only ones to be treated. How about outside your practices? Sure, educate people, podiatrists, PAs, NPs. Many of them have no idea how to evaluate patients with vascular disease. You teach your referral base that if someone has a wound, that's not something that's going to get better with Pletol. You actually need to try to improve the vascular space, and then be clear on indications, especially if you're starting new things like what's coming up now with TAVR and left atrial appendage closures. So people ask, how do you develop outreach? Usually it's because you have a relationship with an outlying clinic. So we started in Dallas 20 plus years ago, and there are outlying areas like in Greenville, which is 50 miles away, and we had a very good relationship with the hospital there. And then we put a satellite center out there, very much of a spoken hub. Been there for almost 18 years now. Kaufman the same way, about 30 miles away, and in Rockwall the same way. So these are places where we have great relationships, and they're very much of a grassroots way, and those are places where people can count on you to answer the phone when they need something off their plate, and I think that's how you start to develop these outreach clinics. Challenge two is introducing new technology. So early adoption of devices is one way of introducing new technology, but the technical challenges are not as big as the political challenges. So you have to educate people. You can be identified as a local expert if you're teaching people and you're incorporating research that elevates your level of education to people. Refine how you do presentations, not using industry slides, learn new procedures, offer to present those and teach people about them. But the important thing is that people recognize that you're actually someone who is adopting new procedures, and you're not going to shove that new information down their throat, but you're going to incorporate them into growing that. People need to see that you are the recognized leader, and you have to make yourself educated, and you have to make yourself uncomfortable. Really, every year you should be learning something new, if not more frequently than that. And if you're not considered an early adopter, people will sort of overlook you. If you haven't educated your community, they won't go to you for that kind of thing. So incorporate new procedures every year. We did this starting in practice in '96. I learned how to do laser, which people say, okay, you're an expert in this, but over the years, a bunch of other things come as an early adopter, and over time, all of these things, percutaneous AAAs to TAVRs, are things that are presented to you because of patient volumes, and that's how you make yourself uncomfortable every year, is you actually incorporate these things, and if it's not you, it's someone in your practice that actually takes on that energy to learn these new procedures and make themselves uncomfortable. The third challenge is dealing with interspecialty competition. That's the surgical versus the endovascular. And I think the best thing to do here is just have the open collaboration mentality. I think it's difficult in the current system of payment because it is still a fee-for-service model, and until we can come up with a way to change that, this will be a continued issue. But I think that there's no substitute for doing good work. So sometimes when I see endo work being done by cardiologists and I don't see good images of the tibial vessels or I don't see good decision making, I get very frustrated with my own colleagues because that's not the way that you can actually compete, because you are doing a lousy job of that. So know the field backwards and forwards, and do good work. And the last is dealing with local politics. And this is a reality, because in your local center, no matter how much you adopt early technology and no matter how much you educate people, there still will be some roadblocks. The first thing to recognize is that everything is a process. So being a complainer is not going to work. Once you get that out of the way, you have to understand, how do politics actually even work at your hospital? Ask some of your mentors, ask some of your colleagues, change the status quo with excellence, and use data to influence instead of being just loud about things. Be flexible when you can and educate the staff. Don't rant and rave. It really just never does work. And the last thing is, don't be an outsider. So getting into committees, getting on organizational systems where you are part of the solution and not part of the problem, and part of the actual hospital leadership, I think is a good way to get yourself to be listened to and to be able to adopt new technologies as they come to you. And invite other people to speak at the educational programs that you do, even competitive groups. And with that, I think you'll do a really good job. You create a team mentality with you in the middle, the cath lab, the surgeons, the patients, your colleagues and administrators, and you'll ultimately win in the long run. Thank you very much for your attention.
Thank you very much. Wise words, certainly from Dr. Das. Our next speaker is Dr. Berrada, who's going to present Innovation in Vascular Disease, What You Need to Know.
Thank you for the organizing committee to actually, for the invitation. I'm actually not a physician, so I want you to know that. So let's see here. However, innovation is my life. Senior director at the Cleveland Clinic Innovations, and I'm here to give you a different vignette about what's out there when it comes to vascular diseases. So when first I was given this talk and 8 minutes to do this, it was really my thought, total panic. How can I summarize things that are tons of stuff out there in 8 minutes? And I thought about it as maybe my job security here. So I'll start this year and I'll continue next year. So available therapy solutions, medical therapy, physical activities, lifestyle changes, revascularization, cell and gene therapy. My focus today will be more into revasc and cell and gene therapy. So suggested frameworks, just to give us a little bit of structure here. There are different tools that we see in vascularization. There are tools in imaging and also in different indications. Innovation spans across all of these three triads. For me, what I'm going to be focusing on are these stents, drug-coated balloons, some energy-based devices, and can get started. So with stents, there's minimal changes in stent development for PAD. Everybody knows the Supera stent, I think, has great performance. People have been using it. Some very good clinical results have been shown in this meeting. People talk about stenting or DCB, so there's a lot of discussions around that. We'll see how that will pan out. When it comes to bioresorbable stents, new technology, there's strong technical challenges remaining to achieve anything that actually come close to any DES. I think we will not see anything fairly soon, and it will be emerging maybe in the distant future at this time. Just to put in there the carotid stenting, obviously the stents remain the same, but the technology around protecting the brain is very much well established, or actually with the Roadster clinical trial with Silk Road company. I was trying to find the name of the company. They have already shown that percutaneously they can have a very good device that actually not challenges or becomes very equal to what is done today on the surgical side. My biggest topic that I'd like to address and discuss is really drug-coated balloon. Drug-coated balloons, we see them There's a lot of discussions about the efficacy of paclitaxel in CLI. We don't know that yet. A lot of good research, whether it's actually in the clinical side or on the technical side. The impact of new entrants, Stellarex, Remotics with sirolimus, we don't know how will that change actually the efficacy in CLI. The discussion between paclitaxel and sirolimus is prominent. How would that actually change also the field, whether it's above the knee or below the knee, and whether people will switch to sirolimus or not. At this time, we don't know the safety, the efficacy, so what is good for the patient? Obviously, paclitaxel is working very well, but at the same time, we're not sure how sirolimus will come in. Some new entrants as well. 3 different companies, MedAlliance with microparticles, Concept Medical with some organic nanoparticles, and then a new entrant, Advanced Nanotherapies. And with that, I apologize. So with that, we don't know how paclitaxel and sirolimus will actually be coming into these new technologies. So a couple of new emergent technologies in energy base. So one, we have SoundBite. This is a technology that can, oh, thank you so much. This is a very cool technology that I've been involved with as well. It actually provides different crossing of different lesions in a very short period of time. This is a technology from Montreal, and they have been able to cross long lesions for a very short period of time, 7 minutes here. They're doing first animals, first human in peripheral, and we're looking forward to their studies as well. This is another technology. You can see here for flow bypass. The first case was done in Ohio by Dr. Shabor. We're very proud to see the different technology that are brought up to our region. You see that here, some of the clinical results that have been achieved with this technology. You see here, it's a technology that I get very excited about because it's a technology that is addressing people that have no options, so patients with no options. And you can see the outcome of this technology after multiple 6 months and 12 months is very positive for patients that really don't have any other therapies. Here are some of the recent data that they shared with me. As you can see, they address the most needy patients, and then the results associated with this has been very stellar. Plaque modifications. I have two types of devices. Plaque scoring. You can see some devices in there, and then plaque excising. In here, I want to highlight flex scoring, flex dynamic scoring, which is a new device. They're still actually in investigation. What I like about this is the ability to have, so what they do, they actually score the plaque, which in their terms and in their clinical studies have shown that they can actually establish a lower balloon pressure when it comes to opening arteries. Maybe this could be safer for arteries during DCB or just PTA devices. When it comes to gene therapy, very little actually is gone in there. There's a company from the Cleveland Clinic, and then the main PI was Dr. Shishabor here, who has led basically the study around the STOP PAD trial. In here, as you can see, there is no differentiation between the placebo and different dosage. These results have been actually shown and presented, and this basically trial has failed, and the company has folded basically. This is an interesting technology that we came across from Ohio State University. This is actually reprogramming the cells. And what I get excited about this, because they're taking skin cells, they're putting something into them, and then they reprogram them to be basically new vessels. So they use electroporation to put in their cargo in the cells, and you can see in here how the cargo is being delivered into the cell through these nano channels that they've created with needles. In some of their experimentation, they have shown here in the control where they have severed the femoral artery in the control, and then after 14 days, you can see that the limb here is fairly necrosed. What they have done here is the same thing where they have closed the femoral artery, but then after 3 days, they have actually injected in there this, what they call TNT. So these cocktail of genes, and you can see the limb is actually pretty much healthy, and then here with just little necrosis. This is a very interesting technology. It's very early. We won't see it in prime time in the next few years, but their only problem is the depth of the angiogenesis is fairly small. Last one. This is augmented reality and imaging. It's here. I think it's going to come to your practice. I just want to show you a little bit of what's done here. This is for, you can see how the registration is very good. The physician can see very nicely what the structure is. And let's see here. So with that, you've got also other information that are put on top of these arteries or these imaging, and you can do your entire procedure using augmented reality than actually under fluoroscopy. And then next here, you'll see how they can do deployment of different devices. In this particular case, they've deployed a stent here, so you can see that the entire procedure was done under augmented reality, which is very interesting for the future. So in conclusion, unmet clinical needs are still present and patient needs further therapy. I think we know that. We need more devices, more solutions. Innovation is healthy, but also we need to answer some basic clinical questions through randomized clinical trials. So impact of improved imaging could yield new treatment modalities. So obviously this augmented reality stuff is here. It will be here. I'm very, very sure of it. And for gene therapy, still struggling to find its efficacy in PAD, but some new technologies are promising, and hopefully they will be adopted within our hands. Thank you so much.
Okay, thank you very much for that very informative talk. We're going to move on to Dr. Mina for extreme access.
So I'm the new Dr. Mena. So Dr. Mena won't be here for this talk. So Dr. Banerjee asked me to prepare this talk. So this is what I did last night. But actually, it's really interesting because when I was speaking to my colleagues and some juniors regarding this talk, extreme access. So it's in perspective. Some accesses would be extreme for people who are not used to those kinds of accesses. And if we are used to pedal accesses, it might not be, other people might not be comfortable with that. So it's going to be a lot about pedal talk because that's what a lot of juniors wanted to hear. I have nothing to disclose. All right, so extreme access, so it really depends upon complex disease. You could be going into your common femoral artery. That's where we all go to do majority of our procedures. And because of complex disease, it could still be an extreme access. It requires skills, it requires training. A lot of people are trained to do some kind of procedures, others are not. And then depends on what kind of options and what kind of devices are available to you and what kind of options depending on patient's anatomy as well and the availability for the procedure. These are the different locations, the femoral, SFA, we have done profunda accesses in times when we have to go and fix something in the common femoral and the SFA is in trouble. Popliteal accesses, tibial and plantars are common now. A lot of talk in this meeting on both of those. Radial, brachial, again, axillary accesses, we do those for our SVC, for the Impella 5, and then transapical access that we used to do in our structural procedures, and then transcaval for Impella 5 as well as for cable valve placement. And all these shows that skill, training, and appropriate planning is the key for these procedures as well as imaging. Because as tough as a transcaval procedure is also doable if there is the equipment, if there's a skill, if there's an anatomy that allows, because even if you go from the vena cava to the aorta, it is seen that the intra-abdominal pressure is higher, which actually kinds of saves the patient from getting any kind of leak. And then all of these have antegrade and retrograde motions as well. So sometimes we in our procedures have to go through the stents, which becomes really complex and very scary when you're coming out of it. And also within grafts, because a lot of population that I am based in Western Texas, all these used to come in and used to get grafts put in, and now they come back with complete occlusion of their grafts, and all we have to do is go into these grafts and fix them, or go through these grafts to fix them. So what we did, because there was lack of education in my area, it's a huge tertiary care medical center, so I came up with something called the ultrasound access team. I got my ultrasound techs, I trained them to come into the room to be with us and to help out the physicians in tibial access, in even radial access, brachial access, in axillary access, as well as common femoral and SFA access. So we, for the first time, came up with something called the PAD team. So if it's an acute limb coming in, or if it's any kind of complex peripheral procedure coming in, there is a separate peripheral vascular disease team that gets activated. It's not a STEMI team, it's a cath lab team that comes in specifically for these procedures. And I actually showed the administration how it could benefit them and how it could benefit the cath lab, and that's what we did. So what are the training avenues for people? The techs and ultrasound techs, that's actually our duties as physicians to teach them. Meetings and conferences for a lot of fellows, and then skill lab and sim center. So we have our own skill lab and cadaver lab where we do courses for our fellows, our technicians, and also fellows in nearby institutions where we call them in, go over cadaver models as well as simulation models where we do all kinds of training with them. We have the pedal models, the radial models, the femoral models, the IJ models, and then we reciprocate complex disease scenarios to see if they can be trained on that. Peripheral arterial disease is growing like any other disease, even more. And Dr. Mustafa was mentioning to me that there's a meta-analysis that he's cooking that shows actually more than breast cancer and lung cancer, there's PAD, but it's not, it's an underdiagnosed entity. So for example, this is a case, let's say you have the common femoral, the external iliac and the common iliac on your right side. The common femoral access we're all used to, but this is a complex access. Where would you go in? The patient is an end-stage renal disease patient with grafts. You cannot come from above. You cannot come from below. We went in from the other side. There was the only way to cross it. Once a slender wire was through, we went to the occluded common femoral to get and treat this vessel. So this is what we do, and it is a complex case, and it just depends on the availability of equipments you could do. We do a lot of pedal cases, and sometimes that's the only avenue to go in. And the whole question comes in, is it safe or not? Because we go through meeting to meeting. And I also remember Mehdi and I were in ACC where somebody was mentioning about how unsafe it is and how we should not do this. And my question is, there are patients that come into our lab with huge groins, with ulcerated groins, with issues with their groins that you cannot go in, with end-stage renal disease and dialysis catheters and dialysis fistulas that you cannot come from above. And this becomes your only option. And we have seen that like radial cath initially came in and there were people who were against that, but we now see it's safe, it's feasible and effective, and so is pedal access as well. We do entire TAMI procedures just going from pedal arteries, go one into other, treat the patient and come out. We can go by arterial access and by venous access for pulmonary embolism cases, for SVC cases, or if it's bi-arterial cases where we have to go into the profunda and SFA at the same time. And then we have multiple closure devices, and as simple as coming down to a closure device just using a prep gauze folded in a pressure. So that's how safe your pedal accesses could be. You do not need any fancy devices. This is something I came up with in my cath lab, and we're going to be publishing this study. No fancy device, a very small cot with tight pressure, cut in the manner that I train my techs to cut, and this pressure applies, and you can take care of your pedal access. And I saved $40,000 of my lab money last year just by doing this. So, and we can go, if we can go into plantar vessels, we can go into digits as well. If it's radial artery occlusion and the patient is in trouble, you can just use it to cross and go in. We can go as smaller as those vessels and as higher as 21 French and 24 French when we put Impella and RP in a severely compromised cardiomyopathy patient, and we can do that from the axillary artery and the common femoral vein, and patients can walk out of the hospital after they're treated. So it's really credit goes to our community for coming up, because there is a need and innovation follows the need, and the need comes into us giving us equipment and coming up with the skills and the training to have these extreme accesses at our hands. This is another case, completely occluded SVC. And I was like, okay, how am I going to go into this? So I used to think after my structural training that structural is like a really complex thing to do. But after peripheral, I realized that peripheral training is the most complex because you have your hands on so many devices and wires and catheters, and it just broadens your mind that you can come up with equipment and things to help your patients and really treat your patients. So this is when I tell people, if you really want to be a skilled interventionist, peripheral training is the way to go towards. So we went to the axillary vein, we tried the brachial vein, went to the axillary vein, we targeted on the other side, went from the IVC down below, going through the iliac vein, and that's how we treated the severe SVC syndrome. His neck was so thick and his face was so swollen that neurosurgery concept was called because patient was losing senses and function, and was subsequently treated, walked out of the hospital. So the imaging is the key. It depends on, we move from palpation method to fluoroscopy and then ultrasound guidance. So historically, we have used all the things, and now ultrasound has played a major, major part. So I'm going to discuss this very interesting study just for the sake of pedal accesses. This is the prime registry that Dr. Mustafa and Saab are working on, and I had a chance to work with them on this, Peripheral Registry for Endovascular Clinical Outcomes. So this is a prospective multi-center registry, initial patient assessment, endovascular treatment, long-term follow-up for 36 months. First patient was enrolled in January. So 407 prime registry patients, endovascular revascularization between January and April, and ultrasound-guided access per center standard practice. And if you look at the arterial access group, it was femoral, dual femoral, tibiopedal, it was all of them, and just the tibiopedal, just the TAMI technique. And you look at the patient demographics over there, wide range, more of them having all kinds of symptoms, claudication, as well as resting pain, neuropathy, edema, cellulitis, even osteomyelitis. And result access sites were divided: common femoral retrograde 34.6%, common femoral antegrade 33, posterior tibial 12, anterior tibial 12, and also other accesses. And this is the success by access site. Now, if you look at that, I would just point out to below with the, other than the brachioradial, look at this dorsalis pedis, the superficial femoral, the anterior tibial, you have access success with the learning curves in the 90s%, which is pretty successful, even antegrade and retrograde. So retrograde versus antegrade common femoral, there was no statistical difference. Tibial anterior, tibial combined versus retrograde common femoral, no statistical significance in favor of retrograde femoral. But if you look at the complication rate, we're going to talk about that. First, distribution of the access combinations, we have dual in 130 patients, single 188, and 73 were just TAMI. And this is the result of complications. So this is actually, look at the femoral antegrade and femoral retrograde. When we talk about hematoma, so no death, only one AV fistula in the dual. Hematoma more, none in the TAMI group. If you look at all other complications, none in the TAMI group. Look at the fluoroscopy, the procedure time, the hospital stay, all better in the TAMI group. So this just clearly shows when people talk about safety and efficacy of the tibial access, I just cannot agree when somebody says that you cannot do that, because it points out to us direction that is safe and efficacious, provided that you have the training to that and there is a learning curve. Antegrade versus retrograde common femoral, the fluoroscopy time difference is almost similar, procedure time difference almost similar, hospital day are almost similar, and less contrast is used in the antegrade as compared to the other. But it also helped in the CTO patients, the antegrade common femoral. TAMI versus retrograde common femoral, contrast use was statistically significant, fluoroscopy time again statistically significant, hospital stay again statistically significant. And then there's a big difference. There was a huge cohort of these patients that had the first procedure done with antegrade and retrograde common femoral, came back for pedal access, and we were able to cross. So this just clearly shows it's not only the modality for success, but also for treatment. Our limitations were single center. We need more multi-center trials, but it just point out towards the right direction. So I'm just going to skip the conclusion on this, just coming over to crosses versus intervention. This is the big question. Femoral versus pedal, can we do both? Because there is a lot of times I hear that you can only cross through pedal, but do not treat. So then those patients that you're not able to have access from the common femoral or brachial, is there a possibility we can go through pedal and do atherectomies, laser, both CSI, balloon deployment, or stent deployment? Yes, I think it's much easier for me to go from the pedal to deploy an ostial SFA supera stent rather than coming from above, because I can guarantee that result rather than coming from above. That's just my experience and my generation, guys, because there's a big difference between the things that the gurus can do versus the things that we can accomplish. SFA, we talk about proximal, mid, and distal access, and it's a possibility. We talk about segmental revascularization, and when we talk about segmental revascularization, if you're going in to distal SFA, doing the Schmidt or the modified Schmidt techniques, you pass your wire, come in from the antegrade, retrograde from the other side, and then balloon before coming out. So there is a technique, and it is doable with good results. I'm going to go over this case very quickly, these two cases, just to give an example. This was a patient that had multiple revascularization attempts at 3 centers before he came to me. No way to go from above or treat, and we were able to successfully go from below, not only treat the patient, do laser atherectomy and DCB, and the patient walked home. Next, another study. This is going to be another paper that we're going to publish. This is combining all studies up to today. Case reports, case series, studies ever done on pedal, retrograde approach using transpedal access for endovascular treatment of peripheral vascular disease. This is a global case series reviews. The method was combining all the data, looking at complications, including dissection, perforation, embolization, hematoma, pseudoaneurysm, fistula, whatever is included. I included everything. I put my entire fellow task and my dissertation to task for this study. And what we found, 14 studies, 12 retrospective, 2 prospective, 857 patients. Majority of them were men. Most common access site was dorsalis pedis artery, followed by posterior tibial. There were 94% success in the access, 97% angiographic success. And it just clearly points out towards not only success rate, but feasibility and safety. The most common vessel treated was below the knee artery, so there were more procedures below the knee for these things. And the dissection that they reported was 9%, which was also subsequently treated with balloon angioplasty. RAS case, to end with this case, this is the patient that comes to me, well known to me, comes in with grafts bilaterally, and again, huge belly, nowhere to go into this patient. Now he comes in, his entire sign is down, he comes in with acute limb, and we don't know where would we go in because he has grafts on both the sides and the arteries are like completely gone. After coming from this side, now we have to access the graft. We have to access one part from our main artery to the graft, and that's what we did because there was no flow. So we went into the artery, see where the graft is coming out, which is completely occluded. That's where the graft is coming out. I went and turned my wire, including my sheath, from that side, got into the graft, crossed completely, and then had to come from below to cross from below, tunneled, guided the wire down there, and then subsequently treated this patient just because there was no other avenue to go in. So we went through the artery, into the graft, come from below into the graft, tunneled, and that's how we were able to successfully stent and treat him. And after we treated successfully, that's his anatomy. And he's actually doing good, and he's actually walking around and was discharged from the hospital, but the point is he still again started smoking. And that's my population. Thank you very much. I welcome any questions.
Thanks very much for an excellent talk. You prepared on short notice and nicely demonstrated as well. Our next talk is entitled, I Am Proud of This CLI. I like that title. And it's by Dr. Ansari.
All right. So extreme access and CLI go along together. CLI is common, and did you know there are more people alive today than they have ever lived on Earth, 7.6 billion. CLI is common, it's here to stay. Now, this is a case where the question mark is because I'm not sure if I was proud to do this. We discussed in the previous previous session that when do we decide we don't do this case or we do this case, and what do we do with it? So hindsight is 20/20, but I think this is a very routine case for many of the expert operators here. But for me, there were many times when I thought, should I give up? Should I send for surgery? And what should I do? So I would appreciate your attention here. So once upon a time, last year, 58-year-old man, hypertension, history of smoking, 22 years ago had aorta bifam bypass. Bilateral claudication was referred by the surgeon. Patient had more symptoms on the left, but he had already done an MRI, and there was bilateral anastomotic stenosis, and the ABI was a little worse on the left side, and there was multi-level disease. Now, when I saw him in the clinic, he was Rutherford 3 claudication, and I had planned for revascularization. However, just 3 days later, the patient presents with CLI. So he presents with the other leg, which the ABI was actually slightly better at 0.4. He presents with extreme pain and bluish toe, first, second, and third toe. So there will be multiple points where we'll need to stop and think. So you see the graph. The graph looks beautiful from 22 years ago, but this is where all the problem lies. So there is this anastomotic disease here, but there are a couple of rocks here throughout the osteal SFA. So anastomosis, stenosis, osteal SFA, calcified, severe stenosis, and then there are a few rocks downstairs over here. And then let's keep looking. Where else can you have the disease with typical CLI? All right, so then you have a popliteal occlusion, and so we are hoping for some good news. Fortunately, there is good two-vessel runoff. All right, so this is what's causing the CLI in the forefoot. So what are our options? So now do we stop? Fem-tip bypass, pedal access. How about left brachial access? Patient is 6'3". I don't have the radial access kit that's available now from Terumo. Or do we do multi-access? So we'll see. From brachial, I went from brachial, so this is the angioscore balloon because I wanted to plaque modify the anastomosis site, but didn't want to atherectomy it because that would shred the anastomosis site. So that's at the anastomosis site, we did an angioscore balloon, and then we did atherectomy on the CSI atherectomy on the SFA. However, obviously, as you can imagine, the biggest limitation is the length of my catheter from there. So that's the sheath, and then nothing would go below this level. So I proceeded with pre-dilatation and then drug-coated balloon for the whole length, actually up to here, up to the CFA with a 6.0 DCB. So what do we do now? Now we need a straight line flow. The patient is pretty, the toe is pretty sick for any want of blood. So anyway, so this went well. So there's a brisk flow downstairs, but what do we do next? So I went antegrade femoral access because of the catheter length, and then basically try to define the popliteal occlusion better. And I was surprised how ambiguous the CTO was proximally. I spent quite a bit of time, really. This took much long. This was the longest time that it took for the procedure, and could not succeed from antegrade, from up above. So went pedal access, and basically at that time we were able to cross the popliteal occlusion with a 035 system actually. And then we externalized it into the antegrade system, and then did a atherectomy, and then I hope that I didn't have to stent it. Unfortunately, that didn't work too well, so I ended up putting in a supera stent. So why am I showing this case? I mean, this is a regular case that most people here do. So this is what happened next. So anyway, so this is the runoff. I still have the sheath here, and so once I took the sheath out, there was flow in the AT. So what happened? So there are 3 accesses. We get manual hemostasis on them, and then around an hour after that, after the hemostasis, the patient has acute limb ischemia on the right leg. Now, obviously, this is a case that we are showing because of the access points. So what do we do? What are our options here? So first of all, I think what happened was that the whole thing thrombosed. So now I converted a CLI patient to a acute limb ischemia after all this work that I had done. So at this time, we have a hemostasis here, so I didn't want to go antegrade at this time. I just went brachial, took a picture, see what happened. So there's a whole layered thrombus all the way from here. Obviously, this was not like this when we finished it. And then basically subsequent all badness down there, very slow flow, thrombus there, barely flowing here. AT is thrombotic, so slow 2-vessel runoff, and then basically, again, more bad down there. So what do I do here? What do you do? So I thought I'll just take my chances. I start from the basics. So first of all, I went there, and we don't have, so maximum the catheter length will come up to here. So there are 2 options. One is try to do whatever you can do from brachial. I didn't want to go antegrade again because that's the spot where the thrombosis happened. And then the other option is again try the pedal axis again on the DP axis. And the third thing is, of course, is pharmacotherapy. So number one thing I did was I gave some integralin, like coronary double bolus integralin topically from there, and then ballooned it. Actually, then did a DCB and then hoped for the best. So there is a bit of flow here, not perfect, and then there is all this layered thrombus where I cannot get any device down to get it. So then I went ahead and gave more Angiomax. So this time I did with Angiomax, unlike the last time I did with heparin. I gave more integralin topically. And then with all the pharmacotherapy, I really wanted to give the pharmacotherapy the best chance that it can. So I've started getting some flow, but there is, my target is obviously the 80. The 4-foot was the initial problem, and the ischemic toes. So I'm still trying to get this, but I don't have anything to get into. So what do I do? So what I did is I J'd 035 angle glide wire and then pushed it through this 80 all the way down, and I saw it follow up. I knew there was no disease, it's all thrombus. So I J'd it down to hope the best for to get just some flow in there. So with all that, this is all that I got. And then of course this is the outflow. So basically, this is the end result. What I have is I do have flow there, obviously not antegrade. I do have retrograde flow from the pedal from the PT. So at that time, I thought that let's give it a chance. Let's see how he does. So kept him on 24 hours heparin. Next day, I got lucky. There was 3-vessel antegrade runoff, and patient finally did well. At 8 months, has follow-up ABI1 and 3-vessel antegrade flow, no restenosis. Patient saved all his toes and everything else. Thank you for your attention.
Okay, thank you so much for sharing that with us. We're going to be moving on to Dr. Huff, who's going to speak about my worst aortoiliac complication.
Thank you. All right, I have nothing to disclose. I want to thank the committee for inviting me to speak. Unfortunately, this complication happened fairly recently, so it's still fresh on my brain. I do want to point out that because I was trained by Mehdi, I hold him partially responsible for any complication that happens in my cath. So this is a 50-year-old gentleman that came to the office complaining of real deal lifestyle limiting claudication. He was a gentleman who worked on his feet all day, and he got to the point where he just couldn't complete his shift, and so it was jeopardizing his livelihood. When he showed up on examination, he had pretty poor bilateral femoral pulses, and nothing could be palpated distally. ABI was severe on the right, close to being severe on the left. I was concerned he had severe aortoiliac disease. I usually CT those patients. And the CT confirmed that he had an abdominal aortic occlusion with reconstitution in his external iliac arteries bilaterally. So treatment options. Fairly young guy. He does have some coronary disease. I debated, should I send him to aortobifem? Should I approach this endovascularly? How about conservative therapy, Pletile walking program? I do send most of my claudicants to a walking program, but this gentleman, it was already affecting his work. I was very worried he was going to lose his job, so I thought he deserved revasc. So I actually sent him to the surgeons for possible aortobifem. So unfortunately, when he showed up to see the surgeons, he was complaining of new onset angina. So this prompted a Lexi scan. He had moderate RC ischemia. They sent him back to me, said, look, we can't operate. You got to sort out his coronary disease. And we subsequently PCI'd a severe lesion, his Prox RCA. So now he's on dual antiplatelet therapy for at least 6 months. Surgeons don't want to operate on Plavix. He's very concerned he's going to lose his job. He says, please help me. So we scheduled him for endovascular intervention. So initially gained radial access with just a 5-French sheath with a plan to place a pigtail down and get a picture of his anatomy. And then we used ultrasound and micropuncture to gain bilateral common femoral access. This was his initial aortogram, which basically confirmed what we saw on CT scan. This is just a still shot of that. Some more still shots. I can tell you that by CTA with runoff, he had bilateral patent SFAs, 3-vessel runoff bilaterally. This was really isolated aortoiliac disease. So we elected to try and cross from above. This was a multi-purpose A1 catheter and a straight stiff glide wire, and it passed very easily through the occlusion. We externalized it through the sheath, advanced a balloon up from the common femoral sheath. We actually exchanged to a longer 7-French sheath, and then through our balloon we exchanged the wire to a magic torque wire, and then we ballooned the aorta, the iliac, and took a quick angiogram to make sure there was nothing catastrophic, and it looked fine. So the next step was to try and wire through the occluded right iliac and into the aorta, and for the life of me, despite multiple wires, could not enter the true lumen of the aorta. Inflated a balloon, tried to enter the PTA lumen, couldn't do it. So we elected to go ahead and stabilize the aorta and fix that. So stented the distal aorta with a pulmonized genesis, and then went ahead and stented the iliac with the left iliac with the genesis as well, and then tried to wire up into this aortic stent, but it just wouldn't go. So I went ahead and completed the aorta. This is a Palmaz XL, which we mounted on a 10 balloon, and we ended up posting to 14. And then finally, what we ended up doing was just inflating the balloon at the bifurcation and using a Pioneer catheter to enter our balloon. Then we drug our 014 wire up the aorta. So now we have, actually it's a 7-French sheath on the right and a 10-French sheath on the left. Got an 014 wire up the aorta, exchanged that to an 035. And now I think we're home free. We did kissing stents at the aortoiliac bifurcation using covered ICAS stents, and that was no problem. Then extended the stenting on the left with a 8x60 smart stent, self-expanding stent, and turned our attention to the right. Took a sheathogram just to, kind of determine what else needs to be stented, how far down do we need to go. Looked at this and decided to place 8x80 Zilver self-expanding stent there. Deployed no problem. Went into post-dilate fairly conservatively with a 6 millimeter balloon. At 4 atmospheres, he developed significant abdominal pain, which often happens when we're post-dilating iliac stents, and so we came down with the balloon. Unfortunately, his pain didn't get better. Actually didn't have I was flipping the manifold back and forth between the two sheaths, so I didn't have it hooked up at the time. His blood pressure by cuff was normal, but it hadn't cycled in quite some time, so I quickly attached the manifold, and his blood pressure was 62/30. So then obviously I did a sheathogram, and he had this massive perforation right at the transition between the common and external iliac artery where we often see it. So now what? I think here it's just keep your cool. We already had a balloon on the wire, so we inserted it and got hemostasis across the perforation site. Next important step is to get venous access and resuscitate aggressively. So put in a 5-French femoral sheath, gave him a lot of crystalloid. His blood pressure came up to, systolic blood pressure came to the 90s. And then because we already had covered stents in the room, because this was a complex case, put in an 8x59 ICAS stent. The other big mistake that I made on this case was it was a complex aortoiliac case. The guy should have been type and screen, but he was not. He was treated like a routine heart cath, and so he had a CBC and a BMP, but no type and screen. So we pulled blood off the venous sheath, ordered a type and screen, ordered some trauma blood. We called anesthesia just in case he were to decompensate and needed to be intubated, but none of that happened. So this is after deployment of the ICAST. So then we touched up, did some more balloon inflation, and this is the final angiography. You can see there's no perforation, no evidence of extravasation currently. We lost the right internal iliac, but his left is open, and that's the final picture. So follow-up, he only received 1 unit of blood. We probably could have sent him home the next day, but he was having a lot of right lower back pain from this bleed, so we kept him for some pain control. But by discharge, he had ABI of 1.0 bilaterally, ambulating without difficulty, and went back to work at week 3. Thank you.
Thanks, Dr. Huff. Nice case. Next presentation is my worst SFA complication by Dr. Dunn.
All right, again, thank you to the committee for the invitation. So this was my first critical limb ischemia case as an attending a couple years ago. 65-year-old woman, some comorbidities, had known PAD. She'd had a few toe amputations on both sides, and she'd had a history of a right fem pop bypass in the distant past at another institution. So she went to her podiatrist for some necrosis in her left fourth and fifth toes, as well as also on her left heel, and she underwent amputation of the left fourth and fifth toes a few months prior, and the bases of the toes were not healing well. So her podiatrist sent her to me for vascular evaluation, and she did have some Doppler signals bilaterally, but they were pretty weak on the left. So I ordered PVRs, and this is what her initial PVRs look like. I don't know if you can read this well, but about 0.4 on the left, 0.8, 0.9 on the right. So doing okay on the right. But I felt she warranted an angiogram. So here's the initial angiogram. Some aortic disease, iliacs didn't look too bad. And she does have some bilateral common femoral disease, mild, moderate. But this is the main problem here, was her SFA was occluded on the left. She'd had some collateral flow. She reconstituted her SFA distally, and then she subsequently occluded her pop, and then that reconstituted in the AT, and had one vessel runoff to the foot here. So she was getting poor inline flow, and her collateral flow here was not great, and her pedal arch was not robust either. So she's 65. She does have some comorbidities. I thought maybe bypass potentially an option, but I felt that with her comorbidities, she wasn't the most robust surgical candidate. I thought we'd try to do this endovascularly. So I used a wire and catheter technique. I used a stiff angle glide wire to get through SFA, and I used an angle glide catheter and got through it without a lot of difficulty. I did get subintimal for a good portion of the SFA, but re-entered kind of in that distal reconstitution of the SFA. And I actually did go through and verify that by IVUS, kind of getting a sense of where I was in the subintimal space, trying to determine the best therapy following my wiring. So then I used an 014 wire to kind of get through the popliteal into the AT. I used a Miracle Brothers 3. Went through without a lot of difficulty, but it did take a little bit of work and some time, but I did verify that I was in the true lumen of the AT distally. So then I just went through with a chocolate balloon, ballooned open the AT distally, dilated the SFA. Because I was subintimal for most of it, I did end up using overlapping Zilver PTX stents through most of the SFA down toward the knee joint, and had a reasonable result. I was pretty happy with my result. I had good flow to the foot. Her rest pain improved. Her Doppler signals were much stronger on the left foot at the end of the case. But when she went back to her room several hours later, she did get kind of an abrupt onset of left lower extremity pain, and she lost her Doppler signals in her left foot. So I quickly got repeat PVRs just to kind of get a sense of what I was dealing with before taking her back to the lab, which I thought was inevitable at that point. And she clearly had a proximal problem here. So I was concerned that the entire thing had shut down, which it had. So here's my repeat angiogram. You can see her entire SFA had shut down. And you see here in her common femoral, she does have a pretty severe complex dissection. So at that point, I felt, she's probably going to need her common femoral fixed. What's the best way to do that? Can I do this endovascularly? So while I was kind of thinking about options and getting one of my colleagues involved from vascular surgery, I did decide to go ahead and open this up. She was having rest pain. She had no real good signals in the leg or in the foot. So I was able to get an 035 wire through the dissection without a lot of difficulty. I felt confident I was true lumen all the way down. And I just took a 50 centimeter ECOS catheter and advanced it down past my stents where she had reconstitution in the AT, and I just ran low-dose TPA for several hours and had a beautiful result with that. As you guys can imagine, that use TPA in this acute setting, in arterial thrombus, it resolves relatively quickly. And so she had wonderful flow again, but the question is, what do I do with this, and how did it happen? If you look before my intervention, this is the common femoral here. You see some eccentric plaque. You see a branch come off here. This is at the end of my intervention. You see the plaque here. You see the same branch coming down here, but you do see some dye here in the common femoral, and you see that the width of my distal common femoral is not quite the same here. You're starting to see some narrowing of the lumen. And so you see signs of dissection here. This is my last shot during my case, and I did not appreciate that this was dissection next to this branch here. And I assume that was either caused by my proximal edge of the stent, or I had a sheath down here in the common femoral while I was working in the lower extremity, and I don't know if the sheath disrupted some plaque here that then caused an antegrade dissection. So this is what I'm left with. She's now got good flow into her foot, but she has this common femoral dissection. I don't know how many of you would have tried to address this endovascularly. I felt that if I tried to put a stent here in her common femoral, I would shut down her profunda. I felt that the dissection involved it. So I did contact my vascular surgery colleagues and asked if they could just repair her common femoral. They felt that with her new stent in the SFA, they would have difficulty with clamping and hemostasis, and they opted actually just to do a bypass of her entire leg. So they did a common femoral to tibial bypass. And she actually had a nice result. She got through the surgery without a lot of problem despite her comorbidities. They did do an enterectomy of the common femoral, but then they did bypass with a vein conduit. And she had very strong Doppler signals following that. And I still follow her to this day, and she still has a reasonable outcome with good pulses in the feet, good Doppler signals in the foot. So good result in the end. But I did learn a lot about, I'm a cardiologist. I'm scrutinize my coronary shots at the end of my case to make sure I don't have a wire perforation or a complication when I pull my wire out. In this case, I probably should have scrutinized my common femoral a little more after I took my sheath back and took my final shots. Thank you.
Thank you for sharing with us that challenging case, Dr. Dunn. The profunda has humbled many of us over the years. Next case is Dr. Harth from Case Western is going to talk about my worst tibial complication.
Thank you for inviting me to present. This is a little bit of dirty laundry time, I guess. But we all learn from these mistakes, and I think certainly it makes us a little bit more wise for the next cases that come our way. So when thinking about my worst tibial complication, I look back at some of the cases. I often do tibial bypass, but I do like to attempt endovascular approach and not burn bridges for someone, especially with someone with poor conduit. So these cases can be quite challenging. Certainly in the presence of more extensive proximal disease, the cases can be very long and complex. So anyone that tells you it takes just a couple of hours to do these kinds of cases is, I guess, not done enough of them. So they're important to prioritize your revascularization strategies when you go into a case like this with a patient that's challenging with multi-level disease, and really pace yourself, be practical, and kind of just take step by step to reach the goal of limb salvage. So this case is that of a 65-year-old female who had a lot of compliance issues. She was a heavy smoker, coronary disease, prior RCA stenting, poorly controlled heart failure and diabetes, leading to some cardiorenal kidney disease and non-compliance in general. She had a remote ulcer on the right foot, which had healed after an angioplasty procedure, and her current issue was a left fifth toe wound. It was spontaneous gangrene. She had rest pain, so these are tough patients, and anyone with spontaneous gangrene, these patients can progress pretty rapidly. Prior to seeing me, she had an attempted revascularization via an endo approach. This led to not a very good situation, actually aborting the case. She was unable to lie flat. She became very hypertensive and went into flash pulmonary edema requiring admission with diuresis. She was supposed to get medically optimized in the interval to bring her back for an attempted revascularization with an endotracheal with a general anesthetic, and this didn't last very long because she came right back to the emergency room with worsening pain, very quickly advancing gangrene, white count, worsening renal function, and just not doing well. She had a slight troponin elevation on check. She was complaining of some chest pain, was deemed to have a type 2 MI, underwent not a very revealing stress test, but given the urgency of the foot, she did not undergo a cath and was deemed to advance to an endovascular intervention given being categorized as a high risk. So this is the patient's ABI prior to any intervention. She had a pretty good waveform and essentially normal foot on the right and very diminished ABIs and almost flat line at the foot. with an ABI of 0.3, which is probably mostly due to her calcific disease. Her foot, I think some of us, particularly when you see an advanced gangrene this quickly, just happening within essentially a 1 month period, would say, perhaps we've already lost a foot. She has gangrene ascending already close to the ankle. So at this point, here I was being sent this patient who was very high risk from the community. What do I do with this patient? She was clearly not medically optimized. She still had kidney disease, of poor heart, volume overload, and she was refusing an amputation. We had a long discussion about the risks, certainly stating that I wasn't even sure if her foot can be salvaged and she might have still end up with an amputation, but she wanted to proceed. And she needed a general anesthetic to even do an endovascular intervention. So I wish I could get to the punchline and tell you that I took her foot from here to here with a very straight line path, but that is not the topic of my talk. So every time I took a step forward, it was like I took 2 steps back with this patient, but we will try to get through this quickly. So here we are, first day, she had required a general anesthetic, took her to the operating room, we did an angiogram. She had actually pretty good inflow. We got into the groin and took a closer shot and look. She open profunda, but diseased profunda, so already we know we're in trouble, and we can explain the rapidly advancing gangrene in this patient. I probably should have had wider eyes and a lens focusing on this area, which is the common femoral, disease distally, just at the level of the profunda. But we kept looking, and I was maybe a little bit too focused on trying to get something done for her and get her off my table so she wouldn't have massive cardiac arrest or a heart attack. So here we are, we had lumen in the SFA. I said, well, I could put something through there. So we proceeded. We were there to do something, save her foot, so we did. I did. We spent quite a bit of time at the adductor hiatus, which is often the challenging spot. We got past this, used a combination of Viance and ultimately using an Outback device to get through this level. We obviously spent some time here, perforation, dissection, and you can tell by the contrast that lingers behind. Her outflow, I thought, wasn't that bad. She had popliteal, she had a little bit of disease in the TP trunk, but an open posterior tibial artery, an AT that ultimately became diseased and occluded at the ankle. So here we are, we start doing some work, putting in balloon angioplasty and go way back towards the common femoral artery, and balloon angioplasty down into that TP trunk with a 3 millimeter balloon. So, got to check on the way out. Well, we did. SFA, pop, all looked good, and now we lost our outflow. So here I was trying to save her foot, and clearly had tibial disease, and now we had no outflow whatsoever. Was this spasm? Was this thrombosis? Maybe a little bit of both. Did we embolize while we were opening up the inflow? We tried some ballooning. We tried nitro. None of that worked. So at this time, my approach to bailing myself out was putting a lytic catheter. I put a ProStream wire all the way down into that posterior tibial artery and just landed it there to lyse her overnight and with some sheath heparin. So we actually extubated her because I was trying to avoid a prolonged anesthesia and brought her extubated to the ICU. And in a very predictable fashion, she went into flash pulmonary edema. She required reintubation. So now she was, not only did I get her intubation for the procedure, but now she's going to be intubated for 2 days. So cringing all my way back to the OR the next day, there's my ProStream catheter. We got back her PT, and you can tell that she had some intrinsic pedal disease. So this already is a poor marker, and it's with this patient that I think I changed my whole view on the angiosome concept. So we got back in there, we ballooned on our way out, we placed a drug-coated balloon along the POP FEMS area and actually ended up with a fairly decent 2-vessel runoff. And on the way out, here I am, I spent all this time doing all this work, got her some flow, but here I am in that treacherous little middle of the ground area, I guess, if you wouldn't call it that. She had persistent, and did not appreciate how badly this was, but she had persistent disease which I chose not to treat endovascularly at the common femoral and into her profunda. So she did extubate, cardiology was involved, she had very good management of her heart failure and kidney disease, and I ended up with an ABI of 0.6. I like to check everybody afterwards, and this was certainly not satisfying. This was not going to be enough to save that foot. That foot was in trouble. And we did a TMA, and the foot was in trouble. And, marginal healing is a nice way to call this, but this is a very disappointing thing to look at when you just put this when I just put this patient through a couple days of risk of a general anesthetic and intubation, all this stuff. So for a few days, we let her kind of settle out. Actually, her creatinine improved with good management of her heart failure, so that was encouraging. And I thought I'd lost the battle. So we had a long discussion with the patient. I, told her we still had some persistent disease that I thought would be best approached through an open endarterectomy and revascularization of her inflow to get her to heal this foot. And again, she wanted everything done, and she was actually looking pretty good, so we proceeded with that plan. In my mind, even if the outflow did not last very long, my goal for her was to give her back a functional amputation, whether that's a TMA or BK, and I knew no matter what, down the road she needed good inflow to at least heal and save a BKA, so I thought it was worthwhile. So ultimately, we did that, and actually now we're in a better place. Her ABI is near normalized. She had good flow, and after much debridement, revisions, grafting, and IV antibiotics, she did ultimately heal this foot. She is walking and actually did stop smoking. But for me, this patient was certainly not a tibial complication, but more of a tibial nightmare, because that was, the main vessel. And when we're trying to save limbs, and for those of us that really spend a lot of time with CLI, these are tough cases. She was actually able to tolerate more general anesthetic than I gave her credit for, than any of us gave her credit for, but I think, that's hindsight. You can't predict that ahead of time. And I think I would have done things a little differently if I had known that, and I would have, done this with a hybrid approach where I approach it through the groin and then in an antegrade fashion revascularized her SFA, maybe had spent less time, maybe not lost my outflow, and at the same time do a TMA. Certainly we have patients we do this for, and when you do it all in one shot, it actually does, they do very nicely. So when doing a long inflow procedure like this in someone with tibial disease and a single vessel runoff, just beware, keep that in the back of your mind. There's a good chance if you spend a long time, you may lose that outflow, and prepare yourself to bail yourself out. Have things at hand, have them in the background, even if it just makes you feel better if you need to do thrombectomy or lysis. Use self-restraint. Just because you can put a wire and a catheter in it, like I did, doesn't mean that should be the first thing to do. In my algorithm, stick to an algorithm and keep it safe. And then again, this patient really taught me the concept of angiosome. I think there was probably additional work we could have done in her pedal arch, and that's something that she did not get, but maybe that would have enhanced her recovery and got her quicker to a healed TMA. So that's what I have. Thank you very much.
Thank you very much, Dr. Harth. We were scheduled to have 8 minutes of discussion. We're at noon. Maybe we'll have 1 or 2 questions briefly from the panel. And those who spoke before, please come up and join us. Maybe I'll...
I just want to say that it takes courage to present your things that didn't go well, so I applaud each one of you. I think we'll continue the discussions if it's possible and ask some questions. And I also want to mention there is a fellows competition final prize finalists, and these kids have worked very hard, so you guys can support them. Wonderful. Marwane, please. Do you have a question? No.
Okay. Yeah, please.
So let's say this meeting is not a transplant, we're starting their program, but there are very few medical spots, and a lot of people are not trained to do these procedures, but the population of having disease is growing. So there are listen to come to these conferences and their colleagues and stuff like that, and short doses are around. So how can that be better? Because at the same time you go and observe these things to be done, you will still not be comfortable with doing it at a scale where sometimes these complex decisions come. So what would be the recommendation for this?
I don't know if Dr. Huff or Dr. Dunn want. It sounds like you guys have sort of felt that happen a little bit in your practices recently. Maybe you want to comment?
Sure. Yeah. At my institution, we had a group of vascular surgeons that were doing most of the endovascular work, and I think training in cardiology for peripheral vascular disease is very dependent on the program you went to. It's becoming an extra year at this point. I think peripheral vascular interventional training is, if you're in interventional cardiology, is beneficial in any practice, regardless of where you go. Even if you do structural, I still do TAVR work, and endovascular skills are certainly beneficial to have in that environment. So I guess for any interventional cardiologist, I would encourage you to get peripheral vascular training if that's something offered at your institution. And then, I guess when you go to your institution, find out who's doing endovascular work and learn from them. My vascular surgery colleagues, there's some endovascular work they're very good at, and I've learned a lot from them. I think it is a growing field. It's an exciting field, and so I think coming to conferences like this and showing interesting cases and showing new technologies out there encourages people to get into this field and then take that out and be able to serve the population.
I think the other comment I'll add, in our practice in vascular surgery, we commonly participate in every trial we can in new devices, and that creates a forum where our junior partners can be there for those cases, even if it's not their case, to watch the new device X. So that way, when you schedule yours next week, your partner who did it last week is there to make sure that things go smoothly. The more challenging, I think, step is then when that goes to the community, where you do that in an unproctored setting, and making sure that you choose patients wisely, whether to perform in the community or bring it to the tertiary quaternary center. That's where the rubber will meet the road often. And picking, I practice our tertiary vascular practice. We all go to outreach sites, and I do cases at small hospitals as well as our major center. So I think long and hard about which ones I do at X and which ones I do at Y. And our outreach cases are usually as pristine as I can make them for just that reason.
Yeah, I mean, when you come to these conferences, you're not going to learn how to wire a vessel. You don't get hands-on experience, but let's be honest, 90% of intervention is making good decisions, right? Treating the right patient for the right reason. I mean, interventional cardiology was born out of a weekend course that most of these guys went to and then learned how to do it on their own. And think of all the things we've learned on our own since we graduated from fellowship. But I think so much of it is surrounding yourself with wise people who have made mistakes before you and therefore can teach you how to not make those mistakes. And you can learn that stuff from these meetings.
Hi, quick question. I'm Marlene Garcia. I actually live in San Antonio, Texas. This is for Dr. Goodney. I also spent some time researching amputation trends in Texas, and we're not doing very well, especially in South Texas, as you know. But my question for you is, with Agarwal's recent paper looking at endovascular trends going up and, major amputations going down, I want to see what your thoughts are about that in minority population, and Hispanics and African Americans. I don't think it applies to them, but I just wanted to see what your thoughts are with that.
I mean, I think most of the data has shown that access to some type of vascular care, whether it's open surgery, endovascular therapy, just being, or even a diagnostic angio, portends a better prognosis for the patient. Those patients who show up with unreconstructible disease, when managed with their rest pain with narcotics in the community, often by providers who aren't familiar with vascular disease, they uniformly do poorly. So getting engaged with any type of vascular care generally improves results. Whether or not that difference is marginally better or worse in Hispanic or African American or Caucasian populations, I don't think we know yet. I think there's more. Greater disengagement in some of the minority communities that's been tougher to attack, and that's part of what our next step is going to focus on in some of our research. Is we want to make sure that we're engaged in those communities and find out, okay, well, maybe we can get you in for your angioplasty, but why is your A1C 1 billion, and why aren't you taking the cholesterol medicines, and why is your blood pressure 10,000? Because I can do a great job with your SFA or your tibial or whatever it is, but if you don't take all your medicines and control your stuff, we all know it's not going to work. So it's a really a challenging problem, but I think that's where, if you look where the highest amputation rates remain, it's exactly those populations. We can't ignore them.
I have a question for the panel. I don't know if Dr. Beckman's still around, but maybe we'll ask the folks here. So when it comes to surveillance, so I tend to do the 3, 6, 9, 12 model, and certainly for my bypasses, for patients that I did a pretty long segment recanalization on, especially when the initial indication was gangrene or rest pain. So do you all just follow ABIs, or do you follow ABI with duplex? Do you look for high-grade lesions? When do you kind of make the decision to take someone electively, especially when they're asymptomatic? And you haven't had that 2-point drop, 0.2 drop in their ABI.
So the way I answer this, and this comes up a lot,
Yeah.
asymptomatic patient. So first of all, to answer the first question, if it's a non-complex revasc, I'm happy following ABIs. If it's a complex revasc, I follow by duplex. And people always say, well, if the patient's asymptomatic, why take them back? And I think the answer to that is we owe it to the patient. You know, every closure creates an event, and you can rapidly take someone from a claudicant to a critical and ischemic patient by closing. They clot, they throw it to their tibial vessels, and you can watch these people progress down the Rutherford class. So if I'm going to commit to a patient who has claudication and I'm going to dedicate myself to opening their leg, I'm going to follow it very closely and try and prevent closure, which is not benign. It's not just a return of claudication, it's often a progression along the Rutherford scale.
It's an excellent question. It's actually a question that I was discussing with Dr. Huff earlier in this conference because I don't know the answer to this. And I think that the guidelines for surveillance of endovascular procedures, there's not great data behind it. It's extrapolated from the surgical bypass literature. So I tend to be less aggressive with my surveillance. I follow my patients clinically, and I will use ABIs primarily. But if it's a claudicant, I don't have a set standard of when I know, okay, if the ABI drops by this much, should I take an asymptomatic patient back? Is that benign? What are the implications of that? So I tend to base it on symptoms. If a claudicant comes back, starting to complain of symptoms again, I'll take him back. And if it's, I will find it an occluded stent sometimes. And I don't know the answer. I think this is tough because, if you're intervening on all your patients that drop by 0.2, you're going to have complications during your procedures. You're going to have, things clot off. You're going to get distal embolization during procedures, things like that, which could have potentially been managed medically with exercise and trying to keep that vessel open. So I will typically use ABIs. If it's a CLI patient, I'll be more aggressive, like Dr. Huff said, because their first presentation could be a rest pain or a wound, and then you're dealing with a bigger problem. But it's an excellent question. I don't think we have a great answer to it.
We follow everybody with duplexes and ABIs, and if your duplex shows more than a 3x step up, you go back.
I agree. I mean, as someone who does a lot of acute limb for a living, I've seen so many claudicants become acute, a critical ischemia because of a closed SFA.
Okay. Thank you so much. Thanks to all our speakers, and thank you for sticking around.
Yeah.